The broadcast is now starting. All attendees are in listen-only mode.
Hi, good afternoon. Welcome to today's webinar around CalAIM Readiness and Planning in Times of Ambiguity. I'd like to thank everyone who's joined us this afternoon. And before we get started, I have a few housekeeping items to review. Today's webinar is being recorded, and an online archive of today's event will be available in a few days after the session on the Fluid Edge website. If you have any trouble seeing the slides during the presentation, please disconnect and rejoin. We found that to be most effective for problem solving. And you may ask questions at any time during today's presentation by typing your question into the chat box on the lower right-hand side of the window and on the right-hand side of your screen, and press enter. So without further ado, I would like to welcome and introduce today's speakers, panelists. So we're very fortunate to have Scott Coffin, Ruth Watson, and Pam Thompson with us today. As you can see from the bios here on the screen, Scott is a CEO for Alameda Alliance for Health. He has more than 26 years of experience in commercial and Medicaid operations, with a focus in the last 14 years on the integration of public health services and health equity. And Scott, thank you for being with us today. We also have Ruth Watson, who's the Chief Projects Officer for Alameda Alliance for Health. Ruth is an industry veteran with over 20 years of executive management experience in commercial, Medicare, and Medi-Cal operations management. So thank you also, Ruth, for being with us. And last but certainly not least, we have Pam Thompson, who's a VP with government programs here at Fluid Edge Consulting. Pam has 25 years of healthcare industry experience, where she has held leadership roles in Medicare Advantage, product development, quality, claims operations, risk adjustment, and STARS. Again, thanks to our panelists. What we're going to do today is just have what I'd call somewhat of a casual conversation. We'll go through a series of questions that we'll pose to the panelists. We'll ask for their thoughts, opinions, and again, please do feel free to type your questions or thoughts in the chat box as we go through. We'll try to weave questions from the audience into each of the questions that we have with the panelists. I'll facilitate those. So again, thank you for being here. And let's get started with the first question. I will lob it to you, Scott, and talk a little bit, or ask you to talk a little bit about when you have a new regulatory initiative like CalAIM, what are the initial preparations that a Medi-Cal plan should focus on? How do you even get started?
Well, I will start off by saying that years of experience have I think prepared us, but not fully equipped us for CalAIM. This has been something I think, in talking to a lot of the folks that have been in the industry a long time, have not run across in terms of the capacity of CalAIM and how much is inside of this initiative, especially for what is starting here on the 1st of January in 2022. But typically, we start, looking at the policies and looking at the guidance and start to think about, what it's going to take to become operationally ready and prepare the organization depending on the magnitude of the change, the policy change. This one, however, has taken on a new look to it in terms of thinking broadly across the enterprise. And we've had to really look at the domino effect of these policy changes around the transition of the whole person care pilot, the health home pilot. Both pilots we were actively involved in and have been over the last 6 years, and looking at that transition to make sure nobody gets dropped on day one. Also, we add on there the Medi-Cal RX initiative, which is not technically part of CalAIM, but it's at the same time, and then major organ transplants. So combining all of those 4 elements together, we've really had to think in broad terms about what do we need to look at in our operations, what must we get done versus what we put off to a later point. And that's really around prioritization. And that's where really Ruth and her team have been instrumental in helping us map out all of these priorities and really focus in on the things we have to get done, because we've taken an approach that we will not get an A+ on everything we're going to do here. When we cross the starting line on January 1st, we're really going to be building over time. from January forward, and making sure that we understand what it is that CalAIM requires, and across each of the initiatives, and then continue preparing the organization, as well as supporting our members that are being covered through these services.
Thank you, Scott. Ruth, what are your thoughts as far as what plans should be focusing on during this time of uncertainty?
Well, I appreciate all that Scott has said, and it's correct. But I think one thing that he did leave off was right off immediately when we started to look at CalAIM, I think Scott recognized that we needed to get out into the community, and that we needed to engage with our county and the community-based organizations. And we did almost a dozen or close to that, listening sessions with various community-based organizations and people throughout the county. We've worked very closely with the county's healthcare service agency, who actually run whole person care for the county. That it wasn't always easy. It's a new role as a plan to deal with these community things. But if you look at CalAIM, it talks about doing this close to where people live. It has to be in their environment. It has to be local. It has to be something that meets their needs. You cannot do that without getting engaged and partnering with your county partners. So I do think, although it was not always easy, and it's not always something you automatically think of when you're a health plan operations person, I think it's been critical to us moving along and getting to where we are.
Great. Thank you for the feedback. Pam, anything you'd like to add on?
Only that, they, Scott alluded, focusing on what the priorities are for CalAIM, that we are focusing on the things that DHCS is holding close, like transitions and things like that. So there are things that we'd like to have. We'd like to have a robust system that does everything. And so that's great. And we're starting to have the conversations, but like they said, this is just the beginning. And so the prioritization is really all about the member. What are we going to do to make sure the transition to ECM and ILOS is seamless for the members?
Great. All right, thank you. Let's move on to our next question. And again, for the attendees, please remember you're welcome to put a question into the chat at any point. So let's talk about balance. So how, as a plan, are you ensuring there's some balance and implementing this large new program while still keeping the lights on? How do you manage to try to do both at the same time? Ruth, do you want to start with this one?
Sure. A number of things. I think one of the things we did first was we really rationalized our current portfolio. What are the big projects we have? What are the big things that trying to get a handle on where the resources are aligned in the organization, where people are already maxed out. We then took a look at where we needed to maybe augment resources. Did we need to bring some folks in from outside? And what we predominantly brought in was folks that could help us with the project management, the business analysis, those kind of things. We really want to make sure our subject matter experts are engaged in this. Our chief medical officer says on a regular basis that the project team that's doing this, we're the scaffolding, but in the end, we go away. So how do you make sure that this is something that then the existing teams can take on and absorb within the organization? So I think that's a lot of what we've really worked hard at the very top level, all the way at senior leadership, to understand what is on our plate, and to Scott's point, what do we have to do now, and what can we perhaps put off till later? I think that's helped a lot.
Great. Scott, what are your thoughts about how to ensure balance during these times?
Well, I think, Tiffany, we've all experienced the redefinition of keeping the lights on, because it's not just at the office, it's everywhere.
Right.
Today I'm in my vehicle here because I'm up in Sacramento to meet with some of the regulators on some of the initiatives we're working on, and I think our offices have taken on a new location, and so keeping that balance going while everyone was experiencing disruption. And I know a lot of organizations really some great testimonies pulled together. I'm very proud of what the Alameda Alliance team did in regrouping and reassembling and keeping the operational metrics intact. We have dashboards that monitor about everything, but still, with these initiatives that are coming in, there's a lot of, it creates a lot of stress. And I know that's a word that probably is shared too amongst many, is when we look at all the work that needs to get done and we have all this, distributed work environments. But, I'm very proud of what the team has done on pulling together and focusing on keeping the lights on, as well as thinking through, what is it going to take to implement these programs. Lastly, I'll say, and it's a suggestion that I think for anybody that's listening, to do is really, you're not going to get it all done day one. You're not going to be at 100%. As much as we all would like to say we're completed, we have to really, I think, do a bunch of trade-offs and figure out what must we get done versus what can we get done. And then figure out what that healthy balance is. But either way, it's been a heavy toll on our team members, and they've been stretched thin. And I hear that across the state.
Absolutely, always a challenge. Pam, anything you want to add to this one?
Just I've been working at the Alliance, and what I would applaud them for being able to be a little flexible with the project management office in supporting the business so that they can, keep the lights on. So, in typical project management, you have certain tasks and assignments, and there's this fine line between doing the work for the plan. Mm-hmm. And we've been able to be flexible to support however we can. It's an all hands on deck sort of thing, bring it over the finish line.
That's great. Excellent. Okay, so let's move on to our question. So as we all know, the regulatory initiatives around CalAIM continue to evolve. What's your approach, your strategy, your communications to your team about how do we build this program at the same time? I use the analogy of how do we build the plane while we're flying it? How do we continue to build these programs when the guidance continues to evolve, and how do we make our staff feel like they're not doing this all for naught? And so Scott, do you want to chime in on that one first?
Well, I think it starts within the organization, but to an earlier point that Ruth called out in regards to the community and the stakeholders, these services that we are starting here in January are really dependent on our community partners. Mm-hmm. And I think the communications to our partners, everybody's looking for answers, and in areas where answers do not exist, absolute answers. And so we've been dealing with brevity as well as vague, type of guidance in certain areas. And with respect to the magnitude of this policy, that's being implemented as a whole, CalAIM as a whole has a lot of moving parts to it. And everybody wants to know, what does the endpoint look like? And we're still, we're 4 months away, but we're still quite a distance from knowing, all the details we need to operationalize. So at a communication level with teams, both internally as well as our partners in the community, I think everybody's working hard to put together the assumptions, but getting the validations on those assumptions has been a challenge. Therefore, we have to continue to dialogue. We have to continue to meet and talk and work things out. And as the state has provided responses to many of the health plans, that's really between the health plan and the counties to figure out. We're all searching for those answers. And what I will say though, as a closing comment, is it has brought the county administrators and the managed care health plans closer together, especially those that were operating the whole person care pilots and the health home pilots, because we had to figure out how do we make sure that nobody gets missed day one, that everybody that's being served in these pilots crosses over, into ECM and ILOS successfully. And so it's prompted us to think outside the box and really take some examples back to the state, and the Department of Healthcare Services has been responsive to us in answering some of our questions there about are we going in the right direction? Are we thinking correctly? So to that end, the communications has been a constant and will be a constant exercise.
Absolutely, a lot of back and forth for sure.
Yeah. Mm-hmm.
Ruth, what are your thoughts on how do you build programs for items when regulations are continuing to evolve, guidance is continuing to evolve?
I think Scott covered a lot of it, but I do think one of the key things that we have said from day one is we're not going to this isn't going to be perfect. This is going to continue to be a work in progress. It's going to continue to change. I think that message has gone through all the leaders of the organization. Is it frustrating? It's frustrating. But we didn't have the luxury of saying, let's wait until they give us everything we need, because we had a very short window of time to get it done. And everybody has been very motivated on, we're going to do whatever we can to meet this deadline. Will it be perfect? No, but we're going to get there. In order to do that, then you have to keep moving. You can't stop and wait for guidance. You have to do the best you can, be as open-ended as you can when need to be, but decisions have to be made. And I think we've also empowered, Scott and the senior team have empowered the teams to make those decisions, with that caveat of make sure that senior leadership knows what we're doing. But I think that whole governance piece, that whole communication from top to bottom in the organization has helped a lot with that.
Great. And Pam, anything you've seen from the project management side that you would like to add here?
Yeah, the Alliance isn't the only one who's taken an agile approach for like ECM and ILOS for that project. So it just naturally supports an iterative approach to project planning and building. And so we do as much as we can in short building block steps. And so it's okay to start building processes and technology without all of the nodes. So that has been pretty successful.
Awesome. All right, thank you all. Let's move to our next question. And this is around measurement. So how, as an organization, are you measuring and analyzing the impact of new programs on your team? And then what metrics do you consider to track the effectiveness of new regulatory programs? Ruth, would you like to start out with this one?
So one of the things we do with every aspect of every program we do and every project is we start off with sort of our intake process, and part of the intake process is how will we measure our success at the end. Okay. So obviously with this one, some of that is still challenging. We're still waiting on information of how we build our reports. What does the state want back? But we continue to tweak that. We continue to add that as we go through the project, because you have to. So it's a big part of what we do with everything, to make sure that we are tracking things. And that's from the very beginning, the very first thing we do when we scope out the project, how we're going to staff it. We take a look and say, what metrics would we consider to show the effectiveness of this? And many of the regulatory projects you have, that's embedded. This one's a little unique in that they're still working on a lot of it. But you kind of know big picture based on the model of care, based on the things you're asking us to do, that we're likely going to have to track some of these things. So you do your best to build it, and once again, even today, we heard from the state that they know they still want our network analysis, but they know we won't have contracts because we don't have finalized rates. So, I mean, that's a good example, but it doesn't mean we're not building something to make sure that we're ready to do that when the time comes.
Right, I got it. And then Scott, any additional thoughts you'd like to add here?
I think, Tiffany, we've been talking about this for years, and that is around the concept of population health, and we've been preparing for it. So this is almost a pinnacle where it's all coming together, and now we're being asked to demonstrate, what is the value of the social determinants for health. And so there are a lot of case studies out there. There's a lot of information about, measuring effectiveness. The state has provided some framework. There's more to come there as well around how we're going to be required to measure effectiveness. I think first priority is we got to be able to report encounters. We got to be able to make sure that we equip our providers that are non-traditional providers that have not been part of the Medi-Cal managed care system to be part of that system, and they need to figure out how to, and we need to help them, figure out how to report activity. The second part is going to be tracking the effectiveness and define it. But again, we've been studying population health. We've been doing population health for many years.
Right.
It's at a time where now we're getting called out in a sense to show how effective are some of these services. What does housing mean to an individual's life or a family's life? What does food mean? You know, all these other services that are part of the ILOS suite of optional services are really comes around, you know, us making decisions around what does this person really need to improve their quality of life. So
Right.
I'm excited about it. I'm also nervous about it too. I think we all are. You know, we've past 6 years, the Alliance has focused on rebuilding its performance and analytics, and we have a dedicated division and a great team of professionals that study the data, and we model the data, and it involves every division in the company plugging into that, you know, equation in terms of how do we measure quantitatively changes in a person's life as well as qualitatively. So we have a lot more work to do, but progress has been made, and so I'm very optimistic about the future.
I do want to piggyback on that in one thing. One of the things, because we do have a very robust analytics team and performance and analytics, we included them from day one. So they've been engaged in every aspect of this as really leaders in how we look at things and what we capture. So having those folks at the table from the very beginning, I think, has been hugely helpful.
Yeah.
Yeah.
And that's thanks to the good work that you and your team have been doing to make sure that we have inclusion across the enterprise as we're in the planning stages. So it's really back to the organization of what you and Pam and Tammy and Corey and the rest of the team have been doing.
Great, thank you.
Wonderful. All right, Pam, anything to add here before we move on to the next question?
Yeah, just real quickly, I would just add for, you know, analyze the impact of programs on the team. We employ some change management techniques, you know, trying to assess the size of the change, the impact, the org structure. So they're, you know, and creating action plans and escalating when there's, you know, need for assistance with the team.
Awesome. Thank you. All right, now we're going to get to, I know these are Ruth and Scott's favorite questions, the good and the bad. So what element or elements of the CalAIM program excites you the most, and what do you think is most challenging about the program? Scott, let's go ahead and start with you.
Well, the in lieu of services is the category I'll choose. In terms of it, it has both an side to it where I'm a firm believer that we have to go full force into social determinants of health, and we have to take aggressive steps to really look at whole person care. We talked about it in the whole person care pilot. Again, we talk about population health and it rolls off of our tongues very easily, but when you actually get down to what does it take to make it happen? And so just the 14 optional categories of ILOS became very difficult when we started talking through what is it that we can successfully do year one. Of those 14 ILOS, what is our, in a sense of our county, how are we structured? What does the network look like? What could it look like? And when we really started delving inside, we realized that we need to be very cautious, but yet risk-taking, on the number of ILOS that we start with, and then figure out a game plan of how to scale over time. So, the Plan, Do, Study, Act framework has been close to us. The PDSA model, I think it's given a bunch of different names, iterations, is basically how do you iterate the services that you offer, and being that ILOS is not a defined benefit under Medicaid rule, it is optional, and that also made it exciting because we had to kind of patch in some of the corners and figure out what is it that we want to do, and what should we be doing to implement these services in a way that helps people. And then what I find most challenging is also ILOS. It's exciting, challenging.
Right.
The challenge is the discussions don't have an ending point. We continue and we talk about just a single ILOS, and I know it happens in a lot of group settings, where you start talking through, well, what are the possibilities and how far do we go? And, you know, you look at the guidance that is available from the state in regards to the criteria, the eligibility criteria or the frequency criteria. And sometimes, you know, again, you have to fill in the blanks. And, and so that has also been a challenge, and probably where I think we've spent the most time on litigating as well as mitigating, you know, those obstacles. So.
Yeah, makes sense.
Yeah.
And Ruth, what are your thoughts? Your favorite and your most challenging part of the program?
So for someone who's been in this space for a very long time, this is transformative. It truly is a totally different way of us doing things. And our DNA is changing as health plans. These are kind of things that have never been our purview before. Right. And so that's exciting because it's something new. You know, you can see how that impacts the health of our members. At the same time, it's probably the most challenging thing, as Scott says, because it is out of our comfort zone. It isn't something we have a lot of experience with. And we absolutely have to partner with others. And that's not always easy either. It's much, you know, they're teaching us, we're teaching them. And in some cases you want to just say, let's just get it done. And I don't want to have to go to the county or somebody else and say, what do you think of this? And yet, recognizing that although that's a challenge, it's been probably one of the best things we've done. Might as well fight it out now and develop something in partnership that you can both live with when you bring it up live that works. Otherwise, it's not going to work. And so it's been exciting and challenging all at the same time. Not to mention, if you want to talk challenging, this impossible deadline that we're all having to deal with.
Right, the biggest challenge of all.
The deadlines and the changes. So what, yesterday they told us community supports is the new name for ILOS. So everything needs to be, everything from here on out needs to have the community supports now. Like there's a lot that we've done, like 274 is the one example.
Right, always. So I've had a few questions come in the chat as we've been talking, and I'll just throw these out to the group. The first question is, how do you see the visitation of members working with this model? I'm not sure. So Carrie, I don't know if you want to add a little more to that or give us a little more detail about what you're referring to. That would be helpful. While we're waiting on Carrie, I do have another question about staff morale. So you've got this big program coming in. We talked about keeping the lights on while you're asking staff to do a lot. Any little tips or tricks of the trade as far as how to keep staff morale up and how to keep folks focused on the end game and moving towards that?
Well, I'll start. I'd say one is periodic recognitions. You know, is and I think we're constantly talking about that concept of we need to call out individuals by name and just say thank you, you know, for going the extra mile, for working, you know, collectively as one team. And it's hard because when you know, like Ruth was mentioning the deadlines, as the deadlines stack up, all of our other regulatory deadlines don't go away. There is no pause button that can get hit to slow everything else down. But at the end of the day, you know, we've seen people stepping up. We've seen, you know, what I see as future leaders stepping up. You know, that people that lean in to the pressure and help to get the work done. So, but I still think, you know, the strain is real on the organization as a whole. And I think individually, some bear the brunt of that on their shoulders more than others, but there's still a significant across the enterprise impact that's occurring. And so recognizing people is one potential remedy. It's not the only one, but it's one that does work, and to say thank you to people.
I think there is a remarkable energy, though, around this program that is, aside from the stress and the, oh my God, can we make it all done? But everybody seems to Scott's point, they're stepping up, they're engaging, they're, because it's going to transform what they do day in, day out as well. Right. And so we're finding people want to be a part of it more than not. in spite of the challenges. I think we've got a lot of folks that are stepping up. I do think we need to do more. I do think this is a massive change for people and how they do business, and we really do need to do, as Pam says, some work on the change management. I would say because we're so busy delivering, that's probably something we aren't doing as much as we know we need to. It's something we're going to start to engage in more, but we definitely need to do more of it.
Yeah.
To be honest.
I would just add having a sense of humor. So we're fortunate to have Dr. O'Brien, who just brings humor to every conversation, and our project driver, Julianne, who just just said from the very beginning, from the kickoff, let's keep this fun, and she does. She brings it. So we have fun in our meetings. It's not all serious. And
I agree. It's also about not taking it all too seriously.
Right. Right.
We'll get it. We'll get there.
Yeah. I have to keep that good attitude. All right. So Carrie said that she had read that members need to be visited in person for health visits. So I don't know if this is related to ECM that needs to be done or should be suggested to be done in person, but any comments or thoughts on how you're working with members in person versus maybe in a distance manner.
So in the midst of the pandemic, we're being told they're not doing in person as much as they were.
Right.
Certainly they did with whole person care and health homes. And so it is something I think we need to take a look at how we'll do it. But there is that issue of the, COVID is keeping people from doing a lot of things in person. As things change there, then it is something I think that as a process, they certainly did some of that before with health homes and whole person care. So
yeah.
I think we'll piggyback on those kind of processes that were already in place.
Great. All right.
I can just add to that we've kind of had a discussion about what does in-person mean. So you can have a FaceTime or, a Zoom call, and that's face-to-face is not considered, so that there are creative solutions around that. And they're, in the policies and procedures that the DHCS has asked us to say, how are you going to, adopt for the pandemic?
Right. Yeah. Absolutely. Okay, another question from the audience. Health home programs have enrollment in the single digits for some pilots. Will low enrollment rates be an issue with ECM and ILOS, and how do we improve enrollment?
So we don't have single digits.
Right. I would say some pilots, not your program.
And there is a lot of conversation within our county of how we are going to expand that. They feel that there is some pent-up demand, and as the populations of focus get added, there's just automatically more people eligible to join the rank. So we'd like to not have it explode too quickly. We know we are going to expand, and we have to, but we'd like to start off, transition the existing people and then ease into some of the additional. But we are expecting it to, quite frankly, probably almost double in size as we go through the first year. And we do think that's because those folks are already there. There's already folks we've identified that we think can expand on the program. I don't know if Pam, you want to add anything to that, or Scott. Our analytics team has been very helpful in that as well.
Right.
Alameda Alliance self-funded the health home pilot in 2017. So it was 2 years ahead of the state go live for Alameda County. We were in the third phase and we didn't want to wait, and one of the things we did was we lowered the entry bar, the eligibility bar, because we could. It wasn't, following the ACA section 2703 criteria, but we adjusted it to be able to fit well with our whole person care pilot, and also get some experience in how we were engaging with our community-based organizations that we traditionally had not worked with in the past in this way. So I think the encouragement is set a reasonable entry bar, eligibility bar. You'll find that there are a lot of people out there that need that periodic temporary case management support that maybe doesn't fit into your complex case management criteria, but actually could be implemented in a way that prevents them from getting there. And so I would just encourage, look at your criteria and adjust it accordingly. You'll probably find more people than you may have capacity for.
Right, understood. You know, talking about capacity, and you've talked a lot about going right to the community from the get-go when you knew about CalAIM coming down. How, when you're working with those community service providers, the ILOS providers, what are a few of their big challenges when they meet with you and talk to you and want to continue or to expand their services? What are they telling you is keeping them from being able to do so?
The ambiguity of rates and what they're going to, what the criteria is that they're going to, you know, what are they going to have to report? What kind of infrastructure do they have? How are they going to bill us? You know, if they're challenged by that. Most of everybody we've met to is eager and interested.
Good.
But guarded, because, you know, as their margins aren't very big.
Right.
And so what are they going to get paid, and what are they going to have to do for that? What's going to be included in that? And so we keep talking with them, we keep engaging, but there's something answers we can't. Where I think we're in good shape is that we have a pretty robust program within our county.
Right.
And they're all in.
Right.
So that has helped us, you know, in terms of that.
And many of the hospitals, the medical groups, the physicians, that they have back offices. They have staff that, you know, create the bills, you know, create the claims, you know, and we have the back office that processes and pays those claims. The care entities now that are coming into the Medi-Cal managed care system, not everybody has that. And I think that's been acknowledged statewide in every county, is that they don't have that administrative staff and the systems and the processes in place yet. And that's what they're running toward now, is to be able to get all that stood up, not by January 1st, because some of this is going to take a lot longer than that. I think that goes to the point of why the state asked the managed care plans to intervene and, you know, accept, you know, the encounters on unstructured, you know, forms of data, you know, where we would actually reprocess some of those encounters into claims. All that in our, you know, saying that in our county, we have seen a mix of community-based organizations at different levels of maturity, nonprofit organizations that have more active, what I call doers in the organization. They're actually involved in, you know, delivering meals or delivering service in the field, but what they don't have is an administration team in the office that's submitting invoices, generating claims, etc. And that's something that's a capacity we have to build. But that is thankfully where the state has considered some of the incentive funding, is to help some of our partners to invest in those resources.
Looks like we lost our moderator.
Pam, you've been promoted. You're now moderator.
Very good. I would only add, I was thinking for what I've heard in the listening sessions, that there are people who want to offer other services that aren't even on the list of the initial 14. And so they're really, it's getting a lot of momentum, and where the community agencies are seeing opportunities to help people.
We definitely lost Tiffany.
Pam, do you want to carry us on to the next question?
Let me see if I can find the deck. Just one moment. It was in the, I've been made the presenter. Oh dear. Sorry, the deck was in the beginning. It said handout materials, but I don't have access to that anymore. So I need to go.
Well, I have the questions here. You want me to go ahead and moderate it?
Oh, there you go. Self-moderation. Love it.
Yes, let me pull it up here, and I'll see if I can keep us going until Tiffany rejoins, and then she can assume the the moderation. Let's see here.
Looks like Tiffany may be coming back.
Is she
Yeah,
coming back?
I'm back. So sorry.
Oh, okay, good. We were just gonna
Actually became a black hole.
yeah. Well,
I did get.
I think it goes to another point is interventions and initiation is through the past 2 years. It seems like everybody, steps up and gets us through these unplanned situations. So CalAIM being one of them.
Right, just one of many, I'm sure.
Yep.
Excellent. All right, so I'll just ask our attendees if they have any more questions, please feel free to go ahead and put in the chat. I think we've gotten through the majority of them here. I'll give one more minute, and Scott and Ruth and Pam, you can think if you have any other closing comments, but I do have another question for you. Some managed care plans, like BSC, are providing the infrastructure to CBOs for case management and operations. Given the challenges that CBOs face, does it make sense for managed care plans to provide the infrastructure for CBOs for ECM and ILOS?
Ruth, did you want to take that one first?
Sure. I think we're in a unique situation that we probably, from the ECM perspective, I think we don't have to do that. We have a lot of community-based organizations that already participate in whole person care and health homes, and they want to expand. So I think we're lucky for that. On the ILOS piece, I think we are going to as we go through this and we identify community support services that we now have to do, we will take that as a case-by-case basis as we look at a new provider. If we identify a small provider that we think is good, but that this is not their area of expertise, they don't know how to bill us, we've already got our IT department on notice that they may have to convert, for instance, invoices into some sort of encounter information for us. So they're already starting to look at those kind of things, because we do know we're going to have to take some of that on for some of our smaller CBOs.
That makes sense.
Yeah, I would also suggest that organizations, managed care plans, really consider how much they want to take on. There's some work, obviously, we have to step in. We do it already today with our hospital partners and physicians that have issues in terms of submitting encounters. And if you look at the encounter dashboard at the state, you'll see that a lot of positive direction has happened on encounter submissions, and the scores are much better than they used to be. That said, do you take on the back office process for transcribing from unstructured forms of data and creating standard transactions that get submitted to the state? That's a big undertaking. Think about aggregating service organizations into the model. There are a lot of service organizations that are on the wing right now trying to get inside of this CalAIM opportunity. And some of those service organizations can actually help those community-based organizations with encounter submissions. And so, think about partnering with others to achieve the same outcomes, not taking it all on yourself.
I think
And that's something we're going to have to do as well.
Right. We're also working on some criteria of how we would vet somebody who wants to get in this space with us. What kind of capabilities do they have? What is the volume they have now? Who are the members they're serving currently? So we're putting together some kind of checklist like that we'll use for everybody to assess people's operational readiness. And it may be that we say to them, well, you may not be ready now, and it might be somebody we might partner with you down the path, but here's the things that will need to get fixed. So to Scott's point, we're not saying especially when we stand it up, that we'll take on every agency. So.
And I think, Ruth, that the DHCS has been very supportive of the flexibility to say, if a partner is not ready on January 1st, maybe they're ready on July 1st, or maybe it's August 1st. We want to make sure that, again, for the health plans, there has to be a line that you draw around how much you take on, because at some point it could collapse on you. The sheer weight of it could cause you to collapse, and that's what you don't want to do. So you can also think about pushing dates out with some of those partners.
Great suggestions. Thank you both. I do have another question that's come in. It's around communications with staff. So, again, this is a big initiative and lots of moving pieces. And how do you keep staff informed and, again, marching to the same drum while still doing the work? How do you try to make that balance? How do you manage that balance between communications and making sure the staff know where you are going?
Well, communication, I think we touched on it earlier, is a constant requirement. You have to not only recognize, but you have to keep talking about what it is, not just what work is happening, but actually what's inside. We spent a considerable amount of time, not just with our staff, but with our board of governors, talking through what is enhanced care management, and how does it fit into the work we've been doing historically with the county and with our members. How does it, in lieu of services, being an optional service, how does that fit in defining what is inside, and then updating on the status as we move forward. I would say that we haven't done enough communication because you can't communicate enough about it. It's just making sure that they stay informed, but they also understand what it is you're doing. Because in lieu of service, when you say ILOS, acronyms start floating around, and pretty soon they don't mean a lot to everybody. They have to understand and personalize it to their role in the company as to how do they fit into the delivery of that service. I don't know, Ruth, any thoughts?
I agree with that. I also think that one of the things we've done is we've communicated often, frequently. We communicate at every leadership meeting. We talk about what we have from the beginning, what we're doing. Hey, stay tuned because you're going to be involved. It's coming. It's going to involve everybody across the organization. We talk about it in an all hands meeting. We've talked about it a lot of times, and we've repeated ourselves a lot. To Scott's point, what is ECM? What is ILOS? How does it make a difference to us? That kind of thing. So we've also gone to a couple of staff meetings, internal meetings within different divisions and departments to present what is this and what's coming. What's happening now is, because it is so enterprise-wide, most every department in the organization has somebody that's involved in one of our operational readiness teams. And so as we've gotten into the operational readiness piece, and I think one of the things we've done particularly well is this whole agile approach is, all right, we want to talk about this piece. Who does that involve? Who's involved with the communication to the members? Let's make sure we bring everybody in who can go through that and walk us through how we should do it. And that just brings in more and more people every time we do these things. So I think at this point, we have an awful lot of people within the organization who are engaged in this day in, day out, frankly.
And Ruth, you and your team facilitated the community listening sessions. Can you share a little bit about, because I think part of those listening sessions you were actually educating as well, right?
Yeah, one of the other things that was really good is that we partner with Anthem. So we're a two-plan model. Anthem Blue Cross is our partner. We early on decided that, although we're two very different organizations, we should be in sync on this because we don't want to confuse our members. We don't want to confuse the providers. We want people to understand. So to Scott's point, the initial part of that, depending upon who we had, because we customized them a little, was to educate the community. What is CalAIM? What is ECM ILOS? What are the deadlines? What are we trying to accomplish here? And then once we got through that 15 minutes, then it was, now we want to listen to you. Talk to us about how you fit in, what you think the needs are in the community. That was very helpful for us. We learned a lot about, and then part of that also was we had an entity interest form that we also brought, and we dispersed those to the organization and said, if you'd like to be part of this, tell us how you think you'd fit. Tell us what kind of things you can bring, what your experience been, and we've that's helped us as we've tried to identify now community service partners. So I think the listening sessions have been very important, and we did a sort of short listening session for our own employees. We made that available as well to say if you need so people have heard a lot from us. Sometimes I think what they hear is blah 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 blah. We talked so much about it. a ton of advocates within the organization who can answer those questions. It doesn't have to be just one or two people. We've got a lot of people now who can really address this.
Yeah.
That's great. You have your army that is representing you. That's lovely. I do have another question from the audience about next steps with CalAIM. So looking beyond 1/1/22, which is hard for I think any of us involved in it right now to think much beyond 1/1/22, but what do you see as the next big deliverable for deliverables in CalAIM? Is it NCQA? Is it DSNP? What kind of gives you the next maybe level of heartburn coming down the pike for CalAIM?
Well, certainly for us, it's paying close attention to those populations of focus and when they come on board. And are there things now that have to be different for them? Now we're going to serve children in ways we've never served before. We don't, as a two-plan model, we don't have long-term care, and so we're bringing the long-term care population and services in-house. It's a large undertaking for us to take a look at. Another one that's just specific to us, our county behavioral health has been very involved in the SMI population, but they haven't done ECM. They'd like to be ECM. We've been talking with them, and they've decided they'll come on July 1st. So we have 6 months to work with them on how that'll work. So lots of things in the next several months.
Yeah. I'll say there are two that I think have been on my mind a lot, and that is, one is the intersection of Medi-Cal and the justice system with coordinated reentry. Because I would encourage everyone to get to know, your probation and your correctional representatives here in your county as soon as possible. Start relationship building, start to understand how coordinated reentry could look like and what it looks like today. The second is the behavioral health for children in schools. This is a new initiative that has been added on to our plates, and this is also forcing a relationship where historically relationships have not existed directly between managed care plans and superintendents and school districts. In Alameda County, we have 22 school districts. We have 250,000 children in the school system, and we have an array of behavioral health services that are occurring inside of the schools, but we have not seen that in the past years. And now we will. We're going to be part of that model.
Right.
And so I think building the relationships, I would encourage start in those two areas to get to know what's in place today, especially around the coordinated reentry, because that is going to be one that I think it's coming in next year later, but it takes a lot of time to actually stand it up.
Great advice. Well, we have made it through our questions from the audience. Is there any last words of wisdom, Ruth, Pam, Scott, that you'd like to share with the group before we close?
Honestly, for me, one of the key things I think that has made this, that's important for people to keep in mind is that you don't have to be perfect on January 1st. I do think that has helped a lot, and that message has come from the very top in our organization, and it helps so that people don't feel this, is there pressure? Yes. Is there a lot of stress involved in this? Of course.
Sure.
But everybody knows we're going to do enough to make it happen, get it done, and then you keep working it. And that's that iterative approach. I think that really does help a lot to get through this.
Wonderful. Well, again, Pam, Ruth, Scott, I'd like to thank you so much for your valuable insights today. Thank you to the audience for participating in the webinar. And we now conclude today's presentation. Thank you and have a great rest of your day.
Thanks.
Thank you.
Bye-bye.
Have a good day.